Donna, thank you so much for joining us and for agreeing to be a member of our board of directors. Very excited to have you. For those who don't know, Dr. Donna Shalala is the former Secretary of Health under President Clinton, was the president of the University of Miami, and served as a member of Congress for South Florida for the 27th District of Florida. Is that right? 27th?
No.
Got that right? Excellent. Among many other accolades, and we're delighted to have her as a member of our board.
Well, I'm delighted to be here and excited about joining the company.
Wonderful. So I wanted to spend just a few minutes getting to know a little bit more about what you're thinking about in healthcare policy today. There's a lot that's been going on, particularly as the Biden administration has sort of assessed Medicare policy and healthcare policy writ large. Curious, what are the most exciting trends that you're seeing on the policy side?
Well, clearly, the Biden administration changed some rules during COVID. The introduction of telemedicine, the broadening of telemedicine. It's really come into its own. This is probably the golden age of telemedicine, which is very important for seniors. But it's not just the camera and they're getting on Zoom calls with their doctors. It's also the use of the phone for consultations. And I've been impressed with the fact that the specialists like it. Well, I expected the primary care physicians and the advanced practice nurses to find it important, but the fact that the specialists are very excited about it and want it to continue, I think is important. And of course, they made vaccines free as well and made it easier for people to stay on Medicaid, to enroll and stay on Medicaid in particular. Medicare Advantage is booming. I mean, I come from South Florida, where 70% of the people are in Medicare Advantage. But we expect in the next couple of years for half of the population, 65 million people, to be on Medicare Advantage. So the fact that it has more flexibility now, I think is a reflection of the research on social determinants of health. 2019, we expanded the flexibility, and those kinds of things. And of course, at the end of the day, we're going to see whether the Secretary of Health and Human Services, one of my predecessors, can negotiate the prices directly, at least the most important drugs, the most expensive drugs, the ones that are used by most people, directly with the pharmaceutical companies, which they've never been able to do on behalf of Medicare. That could be a game changer.
Mm-hmm. You mentioned a lot of the choice that exists in South Florida. I think South Florida probably has among the highest, if not the largest number of Medicare Advantage plans available to residents and citizens of South Florida. Are there any lessons you think the rest of the country should take from what Florida has done?
Well, South Florida in particular is a very special place. It is not a place that has large industries. It has a lot of small and medium-sized businesses. And they took advantage of Medicare Advantage in particular. I think that what happened was really we had so many Cuban-sponsored small clinics, ethnic health plans, and they advertised themselves. They weren't dependent on the navigators. They advertised themselves, coaxed people into Medicare Advantage, and offered a slew of benefits. But I think more than anything else, they made it simple for people. Mm. You go with me to Lyon, the big provider of health care for Cuban Americans. And they pick people up. They take them to their health centers. They serve them Cuban coffee and pastries. The recipient, the client doesn't have to do anything. They're already registered. Dental care is there, as well as transportation and other kinds of services.
Yeah, there are so many benefits in Medicare Advantage plans these days, and more being added each year. There are, of course, trade-offs when you think about Medicare Advantage versus Medicare Supplement or original fee-for-service Medicare. How would you advise policymakers and others to think about those trade-offs? Do you think that the government and insurance carriers should be pushing more and more towards Medicare Advantage, or is it better to have people with strong choice between the two, or how would you guide?
Well, I don't think we have to push Medicare Advantage. I think the private sector is taking the lead, doing the advertising, offering additional benefits. We're overpaying. We've always been overpaying for Medicare Advantage. And so inserting more and more benefits, I think, is very important. So I would let the market do what it wants to do. I would not put our thumb one way or another. But that's just my view. And I think it's been the view of almost every administration.
Yeah. What we see a lot is for those who really understand the trade-offs and the choices, and there are many, people do tend to enroll in Medicare supplement or original Medicare plans as well. It's not quite as stark as I think the general market trends. And I think it's largely because the Medicare supplement plans have such robust general health coverage that isn't network constrained, that doesn't have a lot of the limitations that Medicare Advantage plans have. Of course, they also don't, the original Medicare supplement plans also don't have all the benefits. And so it is really a personalized choice, and that's what we really stress to our members and the people we support. It's make a choice that makes sense for you, here are all the options, and we try to educate people on those choices. To your point, letting the individual in the market decide what's best for each human, because people do have different needs. I'm curious, there's been a lot of debate and discussion, particularly around the Inflation Reduction Act and particularly how it has implicated prescription prices. I'm curious what your thoughts are on where you think the Part D prescription plans may go and how prescription prices may change, or if you're seeing any trends there.
Well, we closed the donut hole.
Yep.
Which was very important to seniors. I remember my mother, when she originally enrolled in Part D, said, "Why this donut hole? What idiots put this donut holes?" And I explained to her that it was a budget decision. It wasn't a rational decision about health care. That's the amount of money they had. So they had to work the system. So they got as many people covered initially. 70% of the people had all their drugs covered. But there was a small group that fell into the donut hole and had to pay out of pocket. So it was a decision that was made about the budget. This administration, Biden administration, closed that gap, which is very important for seniors, particularly for those that choose to use Part D. They offered some additional flexibilities, most recently the capping of insulin. And large millions of people need access to insulin. But at the same time, they capped it at $35. It will cost the government more money, but it's a good thing until we can get to the negotiations, the direct negotiations with the pharmaceutical companies.
You bring up a really great point that it's often really hard for a consumer, for an American, to understand why certain plans are designed the way they are or certain regulations exist the way they do. And it's really hard as an individual consumer to understand, there is a budget and government has to operate within a reasonable budget and create plans in a way that they think is most helpful to the most people, of course. So it's a really good insight for...
Well, it's not a rational process.
Also,
it's not, what do people need? Let's cover it. It's how much money do we have? And let's figure out how much coverage we can get within that budget mark.
Yep. It's we often have our members or potential members ask, why does something exist the way it does? And it can be really challenging, as I said, for people to really understand those complexities and the nuance behind why, because it's often not rational and not clear. So it's great insight.
Well, and Medicare is quite complicated.
Extremely
and every time there's a problem, we add a regulation. So it's, and as a result, it's become so complicated, it's easy to get fraud. There's a lot of fraud in Medicare. I spent a lot of time as secretary going after that fraud, got some of the largest settlements, but we had to put more money into the FBI, more money into the Inspector General to go after the fraud. And it's fraud as simple as identifying people's Medicare, reproducing their Medicare card. Recently, there's been a big settlement in South Florida, and what they did was steal Medicaid, Social Security numbers and Medicare numbers, and then gimmick the system to get millions of dollars.
Are there any silver bullets here? Do you think there's anything that could be done to really mitigate most of the fraud, or do you think it's a lot of little things?
Simplify.
Yeah.
Fraud comes because it's complex. It's the simplification that's important. And it's not that I don't think that there probably is some fraud in Medicare Advantage in terms of what benefits are offered, or whether they cut people off or not, or whether they recruit a certain group of people. My mother used to tell me, my mother lived to 103, so I got a lot of experience with her in the Medicare system and in Social Security. And she used to say that they came to her tennis club to recruit seniors initially when they were first advertising Medicare Advantage.
Yeah, I'm always of two minds about the sort of in-person come to your club or your house, because on the one hand, it's great, it makes it easy, you have a person to talk to, hopefully they're well-intentioned. On the other hand, that person usually doesn't have access to the data and the tools and resources to really consider all the options. Usually most of these Medicare advisors tend to be, or sometimes they work directly for the insurance carrier, sometimes they work for third-party advisors. And it's really challenging for them, especially when they're in person, to have access to the tools and resources to really consider all options, all benefits, and make that trade-off.
That's the genius behind Chapter.
We try.
Well, you do more than try. Your employees are salaried, so they actually don't know the bonus system that exists, or how much money you're going to get from a certain carrier, and that's important. That's a highly ethical way to give people advice.
Yeah, there are really three sort of steps where the incentives are frequently misaligned with Medicare advisors and end consumers. The first is with the contracts that the Medicare advisors have access to with which carriers. So our model has been, it shouldn't be the end user's problem or job to know what contracts Chapter or any other Medicare advisor has. That's our problem. Our job is to get as many contracts as we can, so that we can earn revenue on as many plans as we can. But really the consumer should only care about getting the best plan for their needs. Mm-hmm. So what we do is we have built a recommendation engine that looks at every single Medicare option, and then we recommend the right plan to each person, regardless of whether we have a contract with that carrier, regardless of what we earn on that plan. And that's really hard. It takes a lot of data work, a lot of technology, and a lot of software engineering that goes into it. It's part of why we've recruited an amazing team, I think the best team in New York, maybe the best team in the country across any company to do this.
But it wouldn't have been possible a decade ago because
Exactly.
we wouldn't have had the technology. I mean, Lyndon Johnson, who established Medicare, would have never thought about this.
Yep.
And Medicare has gone through so many changes. We let people under 65 who had long-term disabilities into Medicare in 1972, if I remember correctly. We changed the way we organized Medicare, made it more complex, but also got more people covered as a result of that. We combined Medicaid and Medicare, dual eligibles with really low income people to try to make sure whatever the co-payments were or any other costs were covered. And we've done a lot with Medicare, but we've got a lot more to do. And I think we need to simplify, we need to have oversight, rigorous oversight, but we also need to simplify it for the consumer. We've got to think about the Medicare recipient at 65 or 64 when they're starting to think about it. It's not that they're not sophisticated, it's just that this requires a level of sophistication. When Part D came in, my mother lined up all her friends at Christmas vacation, and I sat at the computer and got them all registered. Now, I was the Secretary of HHS, for heaven's sakes, and it took me some time to figure it out.
Yeah, there's a professor of health economics at Stanford who was on a podcast about a year ago, and he made an offhand comment. It was a podcast about health policy, not about Medicare, and he just made an offhand comment that he has a PhD in health economics, he's a Stanford professor, and he has no idea how Medicare works or how to navigate or how to enroll, and he was approaching the age group, and it's insane that it is this challenging for everyone to navigate. I mean, that's why we started the company. I would love nothing more than for the system to be so easy that we could spend our time on other problems, but it is not that easy, and so that's kind of why we have to spend so much time supporting people in this.
But even if it was simplified, you'd still have to explain choices to people. And you'd still have to follow their doctors and make sure that they were inside the plan that they decided to choose. And the doctors shift around, the hospitals shift around in terms of their coverage. So the need for technology and for a sensitive person working that technology, I think, is what Chapter is really about.
One thing people don't realize is, as you said, formularies, so prescription lists, as well as provider networks, what doctors are in network with which plans, and sometimes the plan benefits. These can change on a weekly or monthly basis per plan. And it's really challenging to keep track of this because usually you don't think about it until you need care. And sometimes when you need care, those options are no longer available. So what we do is we have a set of sort of data running in the background, and we are frequently checking to make sure that people's prescriptions are still on formulary, still covered, people's doctors are still in network, and that's a lot of what we've built behind the scenes. When consumers interact with Chapter, they really don't see all the data, all the technology going on behind the scenes, but there's a lot of engineering that goes into making sure that people get the right Medicare plan for their needs. It's really not simple, as you alluded to.
It's a public-private partnership that's critical.
Absolutely. One area that we've seen a lot of surprising demand actually has been with a lot of partners across healthcare, so providers and hospitals, across financial advisors who are fiduciaries. I'm curious if you've seen the public-private partnership expand in any areas that are more exciting or less exciting to you, and what you think we as Chapter should be doing more to interact with more of these partners.
Well, I think mental health is going to be an area. And we have to figure out how to get people access to mental health. I think that a lot of mental health is going to be done through telemedicine. I think that's the new world. And I've talked to a lot of these startups, and I asked them how they got quality control on the people they hired. It turns out that a lot of senior people, very experienced people, would like to move to telehealth now. They don't want to go back into the office. Now, the more complex mental health issues will still be in offices and in hospitals and in psychiatric wards. But a lot of the other parts of mental health can be handled in a different way. And they're not necessarily going to be linked to Medicare Advantage, but it may be that we've got to keep an eye on them so that we can identify how we can bring them in under their plans.
Do you think that the shift towards seniors wanting more telehealth services was a result of COVID, or were you seeing that before?
We saw some of it before, but the golden age of telehealth is during COVID.
Yeah, absolutely.
And we got better compliance.
Interesting.
We got
What do you mean?
doctors have trouble with people showing up. They have a large number of people that just don't show up for their appointments. They didn't have that with telehealth. They could check back. We've always wanted to use telehealth to make sure people are taking their meds, for example. But more importantly, it's much easier to get a telehealth appointment, to have the doctor, particularly since you're at home, to get connected with the doc or the advanced practice nurse to get advice or about a concern than it is to make an appointment and go to a doctor's office. And I think that COVID has transformed the future of telehealth. I think CMS, the agency in the HHS that manages all of this, has recognized that, and the extension of telehealth will continue for a long time. It's transforming compliance, at least, with healthcare and healthcare itself, and it will continue to transform the doctor-patient relationship and the continuity of healthcare.
Fascinating. Yeah, I think there's often unforeseen challenges with that physical transport. Just getting to an office can be very challenging for people for a multitude of reasons. I think there's
the other thing that's transformed healthcare is the introduction of private investors into the provider networks. purchasing, investing in provider networks, and the squeezing by health insurance companies of those reimbursements, the hospitals sometimes squeezing them on reimbursements. I mean, everybody's trying to get the last buck
Yep.
out of the system. Finally, when I was in Congress for 2 years, we finished the issue of surprise billing and closed the gap. That was when you went to the hospital, to an emergency room. You may not have been awake, and they brought in a consult, a neurologist, but he wasn't in your network.
Not particularly helpful.
And not particularly helpful, and you got a separate bill for that.
Yep.
That has been eliminated by national federal legislation, which treats fairly, I think, who pays, the insurance companies, the docs and the hospitals, and we were able to work that out. That was a big issue in healthcare, and at least we had bipartisan legislation. I want everybody to know there is a way of getting bipartisan legislation. I worked with the Docs Caucus, which was mostly Republican doctors, with a number of my colleagues to work out that legislation.
Amazing. Yeah, that surprise billing is such a huge, or was a bigger issue, still such a big topic on people's minds, whether it happens or not.
Yes, because you ask your insurance company whether this is covered, and the answer is yes, but you don't know about the individuals that are under contract that aren't in that network.
Yeah. You mentioned that there are a lot of companies building for digital health. It is the golden age, I think, of many digital health products and companies. Yet what we see is there still aren't that many companies building products tailored to an older generation, to the boomers, to the senior community, and those that solve real, I think what you call them, hard problems. I'm curious, why do you think that there's not as much investment or product work going into this?
Well, I think some of it is that Medicare is complex to get into.
Yeah.
To get access to CMS, to ask them whether they want to introduce this product, but to get access to Medicare Advantage plans that are expanding products, because some of those companies are starting their own and adding their own benefits and not looking to a small investor that's got a startup. I've been advising a fund that's doing exactly that. They're investing. I can tell them when I read the proposal for the product whether they're going to make money. I can't tell them how much money they're going to make. So part of the problem is the difficulty of knowing whether you're really going to make money. And there are other places where investors can go. So it's not easy. So it has to do with the complexity of Medicare and elbowing your way in. And it has to do with just there are other options.
Yeah. Yeah. It's all about opportunity cost, certainly. Speaking of, what excites you about Chapter? Why have you decided to spend some time with us and help us grow?
Well, I'm fascinated with what young people are doing, like yourself, in terms of trying to find ways to help people, but also to make money. And I'm fascinated with these small startups, and I've been an advisor to a fund, as I indicated. But this one in particular was so straightforward and interesting to me, and ethical, which was important to me, that I was excited about the prospect. I love the idea of working with the new generation of entrepreneurs. So here I am.
Well, we're honored to have you. Thank you so much.
You're welcome.